Hey everybody, it's low carb and keto nutrition specialist Amy Berger coming to you with the one and only keto without the crazy. Let's see, one item of business before I get into the topic today, and that is Adapt Your Life Academy is going to be running my Stall Slayer course in a few weeks. I'm not sure of the exact dates right now, but get on the wait list. I will put a link right below in the notes. It's based on my book, The Stall Slayer, which you can, it's on Amazon, or you can go to stallslayer.com, and you can download a PDF version. So if you want an electronic version, you can have it immediately. It's also on Kindle. So Amazon, you can get it on Kindle or as a paperback. You can order a print-on-demand paperback book. Now, so if you are stuck in a fat loss stall on a low carb or ketogenic diet, that course is for you. And even if you're not in a stall, there's a whole chapter on thyroid that people have told me that chapter is worth the price of the book all by itself. There's also a chapter on setting realistic expectations, dealing with the scale. There's chapters on sleep and stress. I think I might be a little biased, but it's very educational and helpful, I think, even if you're not stuck in a fat loss stall. So get on the wait list. If you're on the wait list, there's no financial obligation. That just means that you will be notified as soon as the course opens up for sale. So don't be afraid to hit the wait list button and get on the list. Okay. Today's topic, before I get into it, I have to give a very, very big caveat and disclaimer that I am not a medical professional. I am not a doctor. I am not giving medical advice here. I'm just stating my opinion and my thoughts on some stuff. And the stuff is, many of you know by now that I do a lot of freelance writing in health and nutrition, most of it related to low carbohydrate and keto and all that kind of stuff. So I'm working on an article for one of my freelance jobs on the need for de-prescribing medication for type 2 diabetes. De-prescribing as in like taking the prescription away from you because you don't need it anymore because keto worked so well, you don't have type 2 diabetes anymore. You don't have metabolic syndrome anymore. You don't have hypertension anymore. You don't have gout anymore. You don't have migraines anymore, whatever it is. And if I ever just say diabetes, because type 2 diabetes is a mouthful, I am referring to type 2 and not type 1. Okay, that's a whole separate thing. Yes, people with type 1 diabetes can do a ketogenic diet. I'll put a link to a video I did on that. But today I'm talking about type 2. So, I listened to a podcast with Gary Taubes a couple of days ago, and he had a really great analogy. He was basically saying that eating a high carbohydrate diet and using insulin and taking all these other oral medications to manage your blood sugar is like taking poison and taking the antidote. And I'm not saying sugar is poison. I'm not saying carbs are poison. I'm just saying it's a helpful analogy for us to use. Let's say there's a big bunch of poison here, and you've got the antidote right there. Well, why don't you just take this poison and then just shoot yourself up with the antidote? Let's do that. Or, here's a crazy thought. Why don't you just not eat the poison? I mean, that's like another viable strategy that kind of makes sense, right? Like, you could eat the poison and dose yourself with the antidote, or not eat the poison. So, you know, when a child or an adult for that matter has one of those anaphylactic allergies to peanuts or shellfish or whatever, they carry an EpiPen for the emergency scenario. They were accidentally exposed or hidden ingredient in something, and they can save their life that way. But they don't carry the EpiPen in order to allow themselves to have the thing they're deathly allergic to. Oh, I've got my EpiPen, so let me just have this peanut butter and jelly sandwich. No. So I was in the course of writing this article, I was reading several published papers written by MDs, clinicians who use low carb and ketogenic diets in their practices and who now routinely de-prescribe. They like decrease dose, stop. You don't need the medicine anymore. And I'm just going to run through a couple of different kinds of diabetes medicines and why this whole thing is insanity. And it's my opinion that this is insanity. I am not telling you to stop a medication or change a medication. Please always work with your doctor or nurse practitioner or PA or qualified medical professional, okay? Now nobody can sue me. So there's lots of different diabetes meds, right? There's insulin. Insulin you inject, and it basically forces more glucose into your cells. Your blood sugar is really high. We don't want blood sugar to be really high. We want to lower it. Let's give you more of the hormone that helps to lower it. Okay. But when you take insulin for type 2 diabetes, you don't get better. It doesn't fix the diabetes. It doesn't cure the diabetes. You know, like Dr. Jason Fung always says, your blood sugar gets better. The diabetes gets worse. The metabolic problem gets worse. And it just, I'm going to detour for a minute on insulin, and then I'll talk about some of the other meds. Insulin is so wacky because it has so many other effects besides controlling blood sugar, right? I write and speak about this all the time. Lowering blood sugar is only one of many, many different things insulin does. So when you take insulin, you're going to have all those other effects too amplified because you're taking more than your body was even producing on its own. And the really interesting thing to me about insulin is, if your blood sugar is high because you have type 2 diabetes, it's because the glucose in your blood doesn't have anywhere to go. Your cells aren't taking it in. They're sort of like, no, we're good. We don't really want any more glucose. Thank you very much. So it sort of backs up and accumulates in the bloodstream. When you give yourself insulin, you're basically forcing the glucose in when the cells otherwise would not take it. And what is the consequence of that? Lots and lots of oxidative stress, forcing energy through a system that doesn't want it. You know what happens like in an electrical grid with overload? The thing fries and shuts down. It gets ruined. It gets broken. Bad juju, right? Why are we doing that with our bodies? We're gonna take more insulin. Our cells are like, no, we really don't want this glucose. And insulin says, yes, you do. You will take this. I don't care. You will take this glucose. And think of it like that, the episode of I Love Lucy with the chocolate factory, that famous episode where, you know, they're okay, it's coming down, the chocolates are coming down at a reasonable pace, and they're putting them in the box, and then all of a sudden the machine is kicked on. Whoa, this is too much, we can't handle it, it's a mess, they're putting it in their bra, they're putting it in their hat, you know. That's what insulin is doing to the cells. It's giving so much, it's overloading. And when you look, this is too much for like a video like this, but when you look biochemically, molecularly, what's going on inside the cell, when you force fuel into a system that already has too much fuel, I wonder what might happen. But again, you don't get better. Insulin doesn't make diabetes better, it lowers your blood sugar. It does. You progress. Don't you get worse and worse and worse? Don't you need more and more and more insulin, or then you need more and more drugs? Then you need drugs to treat the side effects of the drugs. Then you need drugs to treat the hypertension that you're getting. Like, so it's a little bit nutty. Like, okay, but so that's insulin. Let me talk about some of the other drugs, and then I'll talk about why this is so nuts. Well, no, let's talk about each one in its own. We're eating lots and lots of carbs, and we're shooting the insulin to deal with the ramification of eating all those carbs. Like, the carbs are raising the blood sugar. We're going to use more insulin to bring that blood sugar down. Why don't we just not eat so much carbohydrate? Why don't we just not do the thing that's causing us to need the insulin? What a crazy notion that is. There's another drug. There's a drug called acarbose. It's rarely used anymore. I don't think they use it much. But what acarbose does is it inhibits some of the digestive enzymes in your small intestine, some of the carbohydrate digesting enzymes. So if those enzymes are inhibited and you're not going to break down the carbohydrate as much as you digest it, then that glucose is not going to get into your bloodstream. The glucose is not going to get in, but when we have more undigested or sort of like semi-digested carbohydrate passing through to the bowel, to the large intestine where it normally wouldn't be because it would have been absorbed, now what's going to happen? Oh, the bacteria, that gut bacteria in the colon is going to feed on that stuff, and it's going to cause gas and bloating and GI upset, and you're going to have some not so good stuff. So we could eat carbs and take a drug that helps us not to digest the carbs. Or here's a wacky thought I've had. Maybe don't eat so much carbohydrate. I mean, is that even is that even possible? Could people maybe not eat so much carbohydrate, or should they just keep eating it and take insulin and take acarbose? Okay. There's another drug. Well, there's a couple of different classes of. There's sulfonylurea drugs. There are biguanide drugs. There are TZD. I don't even know how to pronounce it. Thiazolidine diones, TZD drugs. Many different individual names of drugs within those classes. And what these drugs do, and each one is different, but as a whole, collectively, these drugs, they help to control blood sugar by either making your body more sensitive to insulin. So let's say you're not taking insulin. Some of these drugs make your cells more sensitive to the insulin you're producing. So it kind of helps insulin work better. Some of them help your body produce more insulin. Through whatever mechanism, they actually cause the pancreas to pump out more insulin. And some of them, like metformin, I think to some small extent inhibits the absorption of glucose, but more so it inhibits your liver putting out glucose. It limits kind of the glucose coming out of the liver, so there's less glucose entering the bloodstream. And then, so again, we could do all that, pump out more insulin, make your body more sensitive to the insulin that's already being pumped out. Or is there some way, stay with me here, because maybe I'm just, this is the musings of a crazy woman. Maybe there's some way that we could actually reduce the body's need for insulin in the first place. If we didn't need quite so much insulin, we wouldn't have to take a drug to cause our body to produce more insulin or be more sensitive to the insulin we're already producing. Is there, am I just wacko, or is there maybe some way that we could reduce the need for insulin? Maybe if we just didn't eat quite so much carbohydrate, we wouldn't need so much insulin, right? And here, before I get to the one final class of drugs I want to talk about, because I saved the best for last. What was I just lost my train of thought. The drugs, the insulin. What was I saying? Oh, Give me a sec here, folks. This happens. I was talking about the insulin and the sulfonylureas and the TZDs. Yes, right. Insulin. I could be wrong, but it is my understanding that if you get diagnosed with type 2 diabetes, it's pretty rare for them to actually measure your insulin, either your fasting insulin level, a C-peptide, or your response, the insulin response to an oral glucose tolerance test. So not just testing your blood sugar after the glucose, but your insulin at those time points as well. So there are a ton of people who get put on these medications to make your body make more insulin or sensitize yourself to the insulin that's there, or at the end stage when those aren't working well enough, give you insulin injections from the outside when without even measuring how much are you producing now. What if you are already hyperinsulinemic, meaning there's already a very high concentration of insulin in your blood? Why would we want more? Why do we want to inject more? Why do we want you to pump out even more? Now, I could see maybe sensitizing to it, maybe, but those none of these drugs is without side effects either. None of them. Not metformin is like the poster child of medications that are like pretty good. Metformin has, you could get a B12 deficiency, or metformin causes GI upset. I mean, maybe that's better than having a blood sugar of 400, but none of these drugs is without adverse potential effects. So it's just really interesting, the insulin, that you might already be awash in insulin and we want to give you more. I can't even imagine it. Why don't we reduce the need for insulin? Let's do something that lets your body need less of this, and then it's going to kind of come down on its own in your body because you don't need to pump so much of it out. And it's very interesting to me. Like, now I understand the rationale that makes sense in my brain, even though if I were a doctor, this wouldn't be what I would do, but I'm not a doctor. We know, I'm clear about that. It's assumed that if your blood sugar is high, then it doesn't really, either you're not, no, I shouldn't say that. It's assumed that if your blood sugar is high, it doesn't matter how much insulin you're pumping out because it's not enough. Whatever it is, it's not enough, because if it was enough, your blood sugar wouldn't be high, right? They assume you must need more. Well, your blood sugar's 250, your blood sugar's 400. Pardon me, I don't know the molar units off the top of my head. We're talking high, whatever it is, high, diabetic, very, very high levels. So it's just assumed, even if you are hyperinsulinemic, you must need even more because you're pumping out a ton of insulin and your blood sugar is still very high. So they just give you the insulin, or they give you these drugs. Is there like some alternative over here that we could look at that maybe there's some way we could reduce the need? And then I said I saved the best for last. These SGLT2 inhibitor drugs, the sodium glucose cotransporter 2 inhibitors. So when your body absorbs glucose, sodium glucose cotransporter, sodium and glucose can be absorbed together. And what these drugs do are they stimulate your body to urinate out more glucose. Your kidneys basically filter out more glucose into the urine rather than you absorbing it. So, okay, we could take a drug that lets me urinate out the excess glucose, or again, am I absolutely nuts? Is this like a wild goose chase? Or could we maybe stop putting so much glucose into the system? We don't have to pee so much of it out if there's not a whole lot coming in. Are you with me? Am I making any sense here? And these drugs, the SGLT2s, I want to tell you what they are. Sometimes I forget the names of the individual drugs in the classes. Oh, it's the gliflozins, it's the flozins. The SGLT, empagliflozin, ertugliflozin, canagliflozin, and the TZDs, the glitazones, pioglitazone, rosiglitazone, and the sulfonyl, the rides, glipizide, glimepiride, gliclazide, nateglinide, rapaglinide, like just, I don't know who comes up with these suffixes of these drugs, but they are, every single one of them has the potential for adverse side effects, some of them very dangerous. The SGLT2 inhibitors, for example, because you are peeing out lots of glucose, and there isn't really supposed to be a lot of glucose in your urine, your bladder, your ureters, your genitals are your like excretory organs, the urinary genitourinary tract. That's what I was looking for. The genitourinary tract. I did take anatomy and physiology. That tract is exposed to a lot more glucose than it is sort of designed to handle. You know what happens? you get a lot of infections. You get bladder infections, you get UTIs. You get something called Fournier's gangrene, which is basically like necrosis, rotting of the genitalia. Okay, why don't, now I'm not saying that's super common. It's not like super common, but it happens. And okay, let me do that. Let me take this drug that has the risk of genital rotting to pee out the glucose that I'm eating. Or, doc, should I just stop eating so much glucose? Like, is that another way to address this instead of me taking that drug? Could I just put less glucose in and then I don't have to find some way to get it out? I wonder if that would work. And I want to see if there's anything else in here. There's even some drugs, some of these drugs that, there is a hormone called GLP-1, glucagon-like peptide 1. I think it's glucagon-like peptide. Don't quote me on that. And GIP, gastrointestinal peptide. There's like a lot of different hormones and other compounds that are secreted in the stomach or in the small intestine, in the GI tract somewhere, that stimulate fullness. They basically send your body and brain the signal, I've had enough. So you eat less. And if you eat less, you're going to eat less of everything, including carbohydrate. So blood sugar naturally starts to come down, weight can start, gradually coming down. But these drugs, what do you think side effects of these drugs are? Nausea, GI upset, stuff like that, because of the mechanism. Okay, now this is not related really to the blood sugar I was talking about, but okay, let's take a drug that helps me feel full. Or is there some way to eat food that would make me feel full, and I'm full because I ate food? I ate food and now my body's like, oh, we just had food, we're good. How many of you from personal experience know that keto or low carb or whatever flavor of carbohydrate restriction you do, how many of you can attest that you're not as hungry as you were when you were eating a lot more carbs? You're maybe not as hungry overall, or you're hungry much less frequently. Many of you have only one meal a day. Some have 2 meals a day and a snack. If you're eating 3 meals, that's fine. And you're not deliberately skipping meals. You're just not hungry. You don't need 3 meals a day and a snack in between every one of them. And yet you're not deliberately starving. It just, you eat when you're hungry, and you're only really hungry once or twice a day. So keto does that naturally. Keto is so good for regulating those feelings of satiety and fullness and calmness around food. And a lot of that has to do with normalizing blood sugar. You've just got this kind of very gentle wave instead of these wild ups and downs in blood sugar all day. So this is just nuts to me. Like Gary Taubes said, let's come back full circle. Are you going to eat all the carbs and then take all the drugs to help you manage the ramifications of having eaten those carbs? Or maybe just don't eat the carbs. Or eat fewer carbs, eat different kinds of carbs, whatever's going to work best for you. So that's just my thought. And like, there's papers on this, of deprescribing. Here's all the stuff. I guess I'll put a link to maybe one of my favorites. It really talks about, all the drugs and all the side effects. Look at this crazy table. And again, never adjust or stop medications on your own. I'm just giving you some opinions on how completely backward this system is. It is backward. And the funny thing, a couple things before we close. The SGLT2 inhibitors are pretty popular because they work. They're pretty powerful. Now you have to be careful with those side effects. Something on keto also, if you are just doing a ketogenic diet, it is very, 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 very rare to have ketoacidosis unless you are taking insulin, or if you have type 1 diabetes and there's a mismatch with the medication or something. Just a normal healthy person, or even if you have diabetes but you manage it well with drugs and insulin, very, very, very rare to have ketoacidosis. These drugs, these SGLT2 inhibitors, are now known, wrote an article about this previously for a freelance gig. These drugs are known to cause what is called euglycemic ketoacidosis. Euglycemic means normal glucose. So you could have the ketoacidosis, your ketone level's really high, your blood is starting to become acidic, and your blood sugar's relatively normal. Usually when you have ketoacidosis, your blood sugar will be through the roof. And so it's actually not super easy to detect this, because doctors will be looking for your blood sugar to be high, and it's blood sugar's normal. Oh, but the ketones are 25. Oh, holy smokes. So euglycemic ketoacidosis, and that can happen in people taking these drugs even when they're not eating a keto diet. This euglycemic ketoacidosis can happen in somebody just eating a high carb diet who's taking these drugs. They can have that. The risk seems to be even higher if you are taking that drug and you do a ketogenic diet. Bad juju. Every keto doctor I know of who's ever stated something on this issue has said they eliminate the SGLT2 inhibitors if and when they put a patient on a ketogenic diet. They discontinue that medication because they know there's this risk, and that's a bad risk. But the reason these drugs are popular is because they are so effective for lowering blood sugar. They even, I'm trying to think, they sort of prompt more fat burning, and maybe it's because they're lowering blood sugar that will naturally maybe lower insulin, and like then some of the good stuff is going to happen. And you know what else happens in some, not all, but people who take this SGLT2? LDL cholesterol goes up. So what SGLT2 drugs do largely is mimic the effects of a ketogenic diet. They lower your blood sugar, sometimes LDL goes up because you're in more of a fat-burning state. Why don't you just do the diet? You know? And again, I'm like, it's just really interesting. I've heard some of the keto doctors we all know and love basically say that when you look at the multiple mechanisms of SGLT2 inhibitors, it looks like a low-carb diet. It's what a low-carb diet does, except a low-carb diet won't rot your genitals. Okay, I was going to talk about one more thing, wasn't I, about the SGLT2? Maybe that was it. I'm looking through the papers here to make sure I'm not forgetting anything critical. Oh, yes, one last thing. I am not anti-medication. I'm really not. I have benefited from modern medicine myself. I've been on and off medications. They have been helpful. Let's not completely badmouth and poo-poo pharmaceutical drugs where they can be of use. You know, there's even people on keto who are doing everything right, and the blood pressure, especially more so than the blood sugar. Sometimes blood pressure is just really, really stubborn, and you're following the plan to the letter, and you can usually decrease, your doctor will be able to help you decrease meds, or if you're on, let's say, 2 or 3 blood pressure drugs, you can get off 1 or 2 of them and you're only on 1. Sometimes people have to remain on something, whether it's blood pressure or some other drug. So if you and your doctor in a joint shared decision-making process determine that it is best for you to take any of these medications, then take them. I'm not your doctor. I'm not anyone's doctor. But and especially some of those drugs, the DPP4 inhibitors and the GLP-1 agonists, the ones that make you feel full. I know very well, because you've all heard me talk about it before, that keto for most people, not all, for most, helps regulate that appetite, controls the hunger, controls the cravings. If you are someone for whom that hasn't happened, I talk about the magical keto pixie dust being sprinkled upon you. If that hasn't happened and you are still hungry all the time, or you're not hungry, but you're eating anyway because we human beings eat for 6,000 other reasons besides actual physical hunger, that's something for you to work on, the emotional and psychological piece of that. But maybe there is something modern pharmaceutical technology can help you with there. Maybe that can take the edge off. Maybe that can make you less likely to engage in those behaviors with food, right? Because A, it doesn't matter if keto helps to control appetite. If you eat whether you're hungry or not, appetite has nothing to do with it, which I think many of us have been there. Or if keto hasn't, for some reason, hasn't magically made the appetite disappear. So I want to be clear about that. I think that it's ridiculous to take some of these drugs, maybe not so ridiculous to take others, but you working with your doctor is not ridiculous, never ridiculous. Do that, be safe, but be educated. When you get prescribed a medication, don't just take the bottle and go home from the pharmacy or the lab or whatever. Ask what it does. This drug lowers my blood pressure, blood sugar. How does it do that? Oh, well, it causes you to urinate out glucose. Oh, and are there any side effects? Could you maybe walk me through some of the side effects I should look out for? Well, you could have a UTI, you could have, your genitals could rot off, so don't just take a medicine. Take the medicine if they're telling you to take it, but be an educated consumer of your medications. Be an educated, informed, proactive consumer. I guess that's it. I did not think this video was going to be 30 minutes, but I think it's worth it. So be an informed patient. I cannot stress that enough. Shared decision making. If you're not having shared decision making, if your doctor is talking at you rather than with you, time for a new doctor. Okay. I will see you next time. Thanks for watching. You know what to do. If you're not already subscribed, why not? Hit the subscribe button. See ya.